Hi, this is Dr. Andreo Spina from FunctionalAnatomySeminars.com. I am making this video today for the Associazione per la ricerca applicate in terapia manuale, or the Association for Applied Research in Manual Therapy, which is an Italian-based website dedicated to providing high-quality, evidence-based information to manual therapists. The association has given me a series of questions specific to my seminar series, in particular to the Functional Anatomic Palpation System series. So what I'm going to do is I'm going to go through and answer all of the questions that they've sent to me, and then we're going to have a small demonstration for the palpation protocol for the Gracilis as per the Functional Anatomic Palpation Systems methods. So the first question, can you please introduce yourself and explain a little bit about your seminars? So like I said, my name is Dr. Andreo Spina. I'm a sports specialist chiropractor, medical acupuncturist, and I have a degree in kinesiology as well from McMaster University. I am the creator and head instructor of the Functional Anatomy Seminars, which consists of two, soon to be three, separate seminar series, the first one being Functional Anatomic Palpation Systems, or F.A.P., the second being Functional Range Release Technique, and the third seminar series that will be coming out in 2013 is the Functional Range Conditioning System. F.A.P., or Functional Anatomic Palpation Systems, is a seminar series dedicated to teaching a specific system of anatomic palpation and assessment to manual therapists of all disciplines, physiotherapists, chiropractors, massage therapists, napropaths, any manual discipline. The seminar series for F.A.P. is divided into three. There's an upper limb, a lower limb, and a spine. They're weekend seminars. And they really go over the location and the assessment of very specific anatomical structures, as well as we discuss a lot of clinical insights into assessment and treatment protocols, as well as rehabilitation for all of the palpated structures. So the F.A.P. system is really the palpation and assessment component of any manual therapy treatment program. Then for the treatment and rehabilitative side, we have the seminar series entitled Functional Range Release. So the functional range release technique is pretty much expands on the basic tenets of myofascial release treatments by not only releasing tissue but simultaneously assessing, releasing, expanding, and strengthening any newly acquired ranges of motion. So the system focuses on the release of connective tissue, and like I said, simultaneously as the tissue is being released, there are components of the system which will begin the rehabilitative component of any treatment program simultaneously while treatment is occurring. The third soon-to-be-released seminar series is entitled Functional Range Conditioning. And this system, if we had F.A.P. for the palpation and assessment, functional range release technique for the treatment and rehabilitative, and then the third is functional range conditioning, which is going to focus on expanding the rehabilitative component and then continuing on into a conditioning program. And the focus of the functional range conditioning is on improving mobility. And just to quickly define what I mean by mobility, as opposed to flexibility, which is the acquisition of non-controlled passive ranges of motion, mobility is flexibility plus strength. So it is focused on the acquisition of controllable ranges of motion. So in other words, we are teaching athletes or any individual really how to not only expand their range of motion to become more flexible, quote unquote, but also how to control or capture that flexibility so that it can be used in functional movement patterns. So the next question is, why did you develop Functional Anatomic Palpation Systems, or F.A.P., and why do you feel that palpation is so important to manual therapists. I really developed the F.A.P system after coming to the realization that as manual therapists, palpation is the most utilized tool for both diagnostic purposes as well as treatment purposes. So I was always puzzled by the lack of emphasis going through the education systems for chiropractors, physiotherapists, RMTs. I was always puzzled by the lack of emphasis placed on the actual art and skill of palpation. And over the years, I've got to teach my systems to many different manual therapists all around the world, and I can attest to the fact that most therapists also share that that kind of confusion as to why it's not emphasized in the educational programs. During the training that I had as a chiropractor, there was a very big emphasis on orthopedic testing as well as on the usage or utilization of imaging. Now, the way I saw it, orthopedic testing was for the diagnosis of what I refer to as macro tissue injuries. So macro tissue injuries are overt ligament ruptures, fractured bones, significant muscle tears, etc. But as manual therapists, we really deal not in the macro tissue injury world, or we do deal in that, but not for the most part. For the most part, we deal in micro tissue injuries. So that is the development of aberrant fibrosis, altered biomechanics, and things along those lines. So for those particular problems, the orthopedic examination really fails to create what I refer to as a manual medical diagnosis. It might give a medical diagnosis, for example, subacromial impingement. Subacromial impingement's a good diagnosis that can be passed off to the manual therapist, but as a manual therapist, just having a diagnosis of subacromial impingement doesn't really define the problem as specific as would be needed in order to select the appropriate treatment methods to battle the pathology. So what I would observe is that most manual therapists, and what I learned in practice is that most manual therapists really have to rely on their touch in order to arrive at a manual medical diagnosis that would allow us to then decide what the appropriate treatment is. And further to that, orthopedic examinations, even if they do produce a viable diagnosis, they don't really guide the treatment as it's occurring. So for example, going back to a subacromial impingement can be a supraspinatus tendinopathy, a bicipital tenosynovitis, a subscapularis bursitis. It could be a posterior superior glenohumeral joint impingement or an internal impingement. It could be several different things, and just having the diagnosis of subacromial impingement really doesn't tell the manual therapist what structures are involved, what is the histology occurring, what exact tissue is undergoing this pathological process which is leading to this pain or dysfunction. So we will need to know that as manual therapists, because we actually have to put our hands on the people. We have to select treatment modalities that will battle the aberrant histology in order to make our patients better. And really, aside from the history, which of course is very important, we are going to rely on our hands. So to answer the question, why did I develop F.A.P? I developed F.A.P so that we can improve our specificity, so that we can be more accurate in both locating the problem and then in deciding what the histology is that is affecting this particular tissue that is leading to the symptomatology. And by doing so, it gives the therapist the ability to better select a treatment program, to better select a treatment plan. For example, if the problem was a tendinitis or a let's say a bicipital tenosynovitis, you wouldn't want to be very aggressive with your soft tissue technique because you're going to increase the inflammation. If it was a tendinopathy, you wouldn't want to simply use ultrasound because we know that that's not really going to help tendinopathy. So really, by defining the problem more specifically using palpatory skills, we can generate a more focused and specific treatment plan and therefore produce more efficient results in the process. The next question is, what about functional anatomic palpation systems makes it a system, quote unquote? That's a really good question, because obviously if you were to believe that the seminars simply call out a muscle, look in an anatomy text, and then point to the muscle, you would think that this would be something that is not worth your while, or something that you would be able to do without having to take an actual course. There's several things that make it a system. The number one reason that it has to account for anatomical variance. As we know, as therapists, all patients' anatomy is not created equal. There's size differences, there's genetic factors that come into play. There's various things that will make one person's tissues very different from another person's tissues. So the F.A.P system accounts for this by using what we refer to as reference structures. Reference structures are very easily located structures that when found, you can then move to different areas of the body, and you're able to assess the areas of the body knowing that you have a good base or starting point to begin your assessment process. So the system will allow the practitioner to know, for example, if the vestigial muscle, the plantaris, does that person have a plantaris? If you don't really have a system and you're just palpating the lateral head of the gastroc, it would be very difficult to decide, is the plantaris there or not? But if you have the reference structures, it's very easy to locate the reference structures and then work quickly and efficiently from the reference structure and be able to land on a particular structure, or to know if there's an anatomical variant involved. The next thing that makes it a system is the concept that even though we might study anatomy in textbooks, which is two-dimensional, of course our patients are not two-dimensional, they're three-dimensional. So your assessments have to account for this three-dimensional problem, as do your treatments. And what I mean by that is, if, for example, you're trying to assess the tibialis posterior, the positioning that you utilize when trying to access the tibialis posterior cannot be the same as when you're trying to access the soleus or the gastroc. Obviously, the tibialis posterior is at the deepest level of the triceps surae. So the F.A.P system does what we call layering, and by layering we are able to distinguish tissue layer so that we can decide, or we have different methods to reach more superficial layers versus deeper layers. And that's important for not only diagnostic purposes, but also for treatment purposes. If you're trying to treat, let's say, the gastroc versus the tibialis posterior, the method cannot be the same. Once you have contact on the tibialis posterior, if you are to do some of the sequences of motions that I see on a lot of other manual therapy systems, you won't be able to hold your contact on the specific target tissue. So the layering system used in F.A.P is a way to account for the three dimensions of our patients and really allow us to be more specific with the exact tissue that we're both assessing as well as treating. Another thing that we emphasize in the F.A.P system is not only locating the tissue. A lot of people might think, for example, they've been out in practice for a long time and that they know their anatomy and therefore they know how to palpate. And the most common comment before the F.A.P seminar is, this will be a very good review for me. I've been practicing for 20 years, so this is just going to kind of be an anatomy review. And then the most common comment after they've taken the seminar is, wow, there is a lot more to this palpation and assessment than I might have given credit for. So not only do we only deal with locating tissue, and locating very specific tissue at that, but we also deal with, once the tissue is located, how do you assess the tissue? In other words, what are you actually feeling for that makes a manual therapist make the decision that this tissue is abnormal and this tissue needs treatment? And funny, because I ask this question when I'm traveling throughout the world, and when I say, what are you treating for and how do you know when something needs treatment? A very common answer is, I don't really know. A very common answer is, I just kind of feel, and when the person says it hurts, then I treat it. But if that's the case, if manual therapists don't really have an outcome measure for their treatment, and I don't mean the outcome measure for the entire treatment program. Of course, the outcome measure would be, is the patient better? But as a manual therapist, you need an outcome measure for personal outcome measure for your treatment. In other words, if you find something that you think is abnormal, you have to know what feels abnormal, you have to be able to treat it, and then you have to be able to reassess and utilize the outcome measure that you've selected in order to determine if your treatment was successful. If you don't have such an outcome measure, how do you know your treatment is completed? A lot of people will say, you know, the time for the treatment is up, but realistically, if you want to create a lasting change in the tissue, you have to first define what the lesion is so that you know when the lesion has been dealt with to the full extent, or when the lesion has been removed. So the F.A.P system really discusses not only touching the tissue, but feeling for aberrant tissue, feeling for lines of tension. We have a system called tissue tension technique, which shows how do we find aberrant lines of tension that might be hindering normal tissue mechanics or normal tissue motion or movement. And then when we have that concept, we know where and when to apply the treatments, and we know when and where the treatment is completed. So that's another example as to why F.A.P is a system of palpation rather than just a kind of point at a particular structure and say, you know, this is the sartorius, for example. So next we're going to give an example of the F.A.P system at work. This example is going to palpate the gracilis muscle. This is a good example because the gracilis muscle is one of those structures which is often claimed to be treated. However, the palpation of it is let's just say, less than specific in most cases. So we're going to go over the reference structure and a quick demonstration of gracilis palpation. Okay, so this is the first reference structure for the medial thigh. If we take the person's leg and let their leg fall right out, we take a broad base contact. The first muscle that pops into your hand, if you perpendicularly strum the muscle, will be the adductor longus. So on the adductor longus, there's two faces. There's the anterior face if I push posteriorly, and there's the posterior face if I push anteriorly. So I can fall off adductor longus anteriorly and track down the anterior face, or I can fall off the adductor longus posteriorly, in which case if I straighten the leg, I'll find myself in the epimysial groove between the adductor longus here and the gracilis inferiorly. And now I'm demonstrating the gracilis. So if I go on the gracilis, I'm now strumming the gracilis muscle.
Oh, that's nice.
Then when I get to the end point, I use a different reference structure. If I get you to do a hamstring curl, I see the tendon of the semitendinosus. So the next tendon medial from semitendinosus is the gracilis tendon. And the last question is, where can someone learn more about F.A.P as well as functional range release and functional range conditioning? You can visit the website at functionalanatomyseminars.com. As well, you can visit the blog at functionalanatomyblog.com. The blog site is updated on a very frequent basis, giving functional anatomy descriptions, or we go over clinical cases. We post a lot of videos, examples of treatments or assessments, etc. You can also join us on Facebook, facebook.com/functionalanatomyseminars. Or you can follow me on Twitter at Dr. Andreo Spina. I just wanted to thank the association for requesting this interview, and I ask everyone to check out their website, www.aratem.it. Thank you.